Hello everyone. So my presentation today is going to be on fluid and electrolyte imbalance in neurosurgery. It's a pretty broad topic, but we'll start off with a review of some of the neuroendocrine physiology, look at some electrolyte disturbances and some common syndromes, and then finish off with fluid management in neurosurgery. This is just a chart showing the distribution of total body water. Intracellular compartment comprises about 55%, whereas the extracellular compartment is 45%. The extracellular compartment is then broken down into functional extracellular fluid, which is about 28%, and this is further broken down into interstitial plasma and intravascular fluid. The sequestered extracellular fluid is mostly fluid that is in bone and dense connective tissue. So the extracellular fluid volume reflects total body sodium, and under healthy physiologic conditions, the plasma sodium concentration reflects the total body water. The sodium and water balance is overall governed by the hypothalamus, the posterior pituitary, and the kidneys. And basically ADH is secreted in response to increased plasma osmolality, which is detected by the hypothalamus, or decreased plasma volume, which can be detected by peripheral and central baroreceptors. General stress or pain or increased ICP can also cause a secretion of ADH as well. The other mediator of sodium and water balance is natriuretic peptides, and these also antagonize ADH's effects as well as angiotensin II effects. They're produced in the brain and modulate systemic effects of circulating ANP, as well as they decrease sympathetic tone via actions on the brainstem. So abnormalities of serum sodium are common in the neurosurgical and neurotrauma setting. Hypo or hypernatremia can sometimes come from aggressive perioperative volume resuscitation, for example, following like trauma or hemorrhage. In addition, dysfunction of the hypothalamus, pituitary, or adrenal glands can also secondarily cause sodium and water imbalance. Really, any kind of intracranial pathology, and particularly traumatic brain injury, stroke, or cerebral hemorrhage, can disequilibrate the HPA axis. Starting off with hyponatremia, it's defined as a serum sodium less than 135 milliequivalents per liter, and normally results from excess free water or improper sodium loss. Clinically, this can manifest acutely as muscle weakness, lethargy, confusion, seizures, or even coma. But chronically, if the symptoms develop over a few days, patients may really show minimal symptoms. Again, it's mediated by mainly ADH and AMP, and with sort of severe hyponatremia, this is something you'd want to correct before proceeding with surgery, and as well as restore the volume deficit. This is a nice chart showing breakdown of sodium disorders and showing the breakdown of hyponatremia based on volume status, whether it's hypovolemic, euvolemic, or hypervolemia. Just going to focus on a couple of these disorders. First is SIADH. This is an umbrella classification for the clinical presentation of hyponatremia with euvolemia, and it's common after traumatic brain injury, brain surgery, or and in intrinsic neuropathology. And the hallmark is continual ADH secretion despite decreased plasma osmolality. However, any elevated ADH is actually not specific for SIADH. Can also be seen in the context of just general anesthesia, perioperative stress response, again, brain tumors and cerebral salt wasting, which we'll talk about later. In terms of diagnostic criteria for SIADH, these patients are usually euvolemic or mildly hypervolemic. They have low urine output as low as 500 mils per day. Their urine is concentrated, greater than 800 milliosmoles per liter. They have low plasma osmolality and, of course, low serum sodium. You also want to exclude other diagnoses like cerebral salt wasting. So in terms of treating SIADH, the goal is to correct the underlying cause while treating the hyponatremia. And so this is normally done by using normal saline with free water restriction. Usually accomplishes this. Loop diuretics can also cause net free water loss and correct the hyponatremia. But it's important to correct the deficit gradually. So 10 milliequivalents per liter over 24 hours, or 1 to 2 milliequivalents per liter in the first hour in symptomatic patients. If they have a severe sodium deficit, you can use 3% hypertonic saline in this case. Other things like tolvaptan, which is a renal ADH receptor antagonist, and dimenocycline, which is blocks renal action at the collecting duct, are also options here. So in the setting of hyponatremia, you don't want to correct chronic hyponatremia too quickly, rather, as a rapid increase in plasma sodium can cause central pontine myelinolysis. Next syndrome we're going to look at is cerebral salt wasting. This is normally a diagnosis of exclusion. Typically is hyponatremia secondary to renal sodium loss. And it's hypovolemia with maintained or elevated urine output. It's possibly more likely in subarachnoid hemorrhages and secondary to the disruption of neurohumoral signals, which results in increased AMP levels and decreased renal sympathetic input. So in terms of diagnostic criteria, it's likely present if the criteria for SIADH we mentioned are met, but the patient has decreased sodium with a trial of fluid restriction. They also show clinical indicators of hypervolemia like decreased skin turgor, decreased serial body weights, hypotension with orthostatic changes. They also have other markers of are nonspecific and not clinically useful. Measurement of urine sodium excretion and urine osmolality may support the diagnosis, but is seldom of practical clinical utility, and so it really is a diagnosis of exclusion here. So in terms of treating cerebral salt wasting, typically normal saline corrects the sodium in many cases. You can also use enteral salts if it's feasible. You can again here use hypertonic saline if there's an inadequate response to the initial saline, or you need a rapid initial correction, as in the case of severely symptomatic hyponatremia. Fludrocortisone can be used in refractory cases, 0.1 to 0.2 milligrams daily. And of course, you want to monitor the sodium levels and fluid balance closely. Moving on to hypernatremia. This is defined as serum sodium greater than 145 milliequivalents per liter. Clinically, this manifests as mental status changes, seizures, myoclonus, hyperreflexia, and nystagmus. Acutely, again, with a rapid rise in plasma sodium, this can result in central pontine myelinolysis. Patients also show sign of intravascular volume depletion, cerebral hypoperfusion, and/or vasospasm. Intravascular hyponatremia can also cause water to move from the brain cells, resulting in decreased brain volume, which then carries the risk of disruption of bridging veins and actually lead to subdural hematomas. So the causes of hypernatremia can be central or nephrogenic diabetes insipidus, neurotic corticoid excess, or it can be iatrogenic with aggressive saline infusion. So diabetes insipidus, broken down into central and nephrogenic DI. Central DI is caused by an interruption of hypothalamic signaling, which can be anatomic or ischemic in nature, resulting in decreased ADH secretion from the posterior pituitary. And again, this is common after traumatic brain injury, tumor resection, or vasospasm of the anterior circulation, or brain death. Nephrogenic DI is characterized by a lack of renal response to serum ADH, which is associated with critical illness, antibiotics, or other renal insults. Common symptoms between them are hypernatremia, of course, hyperosmolality, and of course dilute polyuria. So diagnostic criteria for diabetes insipidus has a classic triphasic response which evolves over days. So it often starts with polyuria greater than 1 liter per hour and hypernatremia, followed by reduced urine output and hyponatremia, and then finally resolution or permanence of the diabetes insipidus. It's frequently transient and doesn't usually present intraoperatively, but more often presents 12 hours after surgery. If there is an intraoperative presentation, it's normally associated with hypovolemia. And because of the decreased plasma volume, this may actually increase the risk of a venous artery embolism during surgery. It's important in diabetes insipidus to differentiate polyuria from the DI versus diuresis associated with fluids or osmotic or pharmacologic agents. And so in terms of treating diabetes insipidus, you want to treat the hypernatremia by estimating the water deficit and then replacing it with free water. In central DI, where there's a decreased ADH, you can treat it with desmopressin, 1 to 2 mics IV BID, or 5 to 50 micrograms per day, as this table shows. Nephrogenic DI can treat with hydrochlorothiazide or amiloride. Again, you don't want to rapidly overcorrect if it's chronic hypernatremia, which can cause a rebound cerebral edema and again worsen outcomes. Moving on to fluid management in neurosurgery. The primary aim is to maintain adequate cerebral blood flow and oxygenation. Patients who have neurological insults. You want to prevent further brain damage, which is caused by inadequate cerebral blood flow. And so it's critical to maintain stable hemodynamics and cerebral perfusion pressure. And so maintenance of euvolemia really is the goal. Unique considerations for the neurosurgical population is that fluid tonicity is important. Tissue edema results in oxygen diffusion impairment, but also directly impacts cerebral blood flow. And it can sometimes be challenging to assess what's optimal for cerebral blood flow. This is a chart showing the complex interplay of factors which influence how fluid administration or volume status can impact cerebral blood flow and oxygenation. So critically brain injured patients are particularly prone to disturbances of intravascular volume, electrolyte and osmotic disturbances due to central neuroendocrine disturbances, and the use of therapies that impair water and sodium homeostasis, further complicating effective fluid management. So there's a lot of factors that are all interrelated here, which make optimal fluid management challenging. So with that being said, what is the optimal fluid therapy choice for use in neurosurgery? Again, the general principle of fluid therapy for neurosurgery is to maintain normal blood volume and prevent a decrease in plasma osmolality. So in a normal blood-brain barrier, the movement of water between plasma and brain is mainly influenced by osmotic gradient. And so in neurosurgery, the osmolality of the fluid is actually the most important factor in preventing cerebral edema. So crystalloids, one of the choices for fluid therapy, are classified as hypotonic, isotonic, or hypertonic based on their osmolarity. Hypotonic solutions here, again, are usually avoided due to their increasing the risk of cerebral edema. And so lactated ringers is avoided in this case, and normal saline is more widely used. Normal saline is isotonic and has equal amounts of sodium and chloride at 154 milliequivalents per liter each. Due to the high chloride content, though, there is a risk of hyperchloremic metabolic acidosis in large volumes because the chloride concentration is higher than the normal plasma chloride concentration. So another option is a balanced salt solution, and in this case, the chloride is replaced with lactate, acetate, or gluconate, and so lactated ringers is a hypotonic balanced salt solution. And because it's hypotonic, it causes a decrease in the plasma osmolality, which, when decreased by 1 milliosmol per liter, can result in a 19 millimeter per mercury increase in pressure of fluid movements across the blood-brain barrier, and a 3% decrease in the plasma osmolarity results in cerebral edema. And so it's not a good choice there. With the other, isotonic balanced salt solutions, studies have looked at these, and they do produce less metabolic acidosis and electrolyte imbalance versus normal saline, but the ICP is not different between the two, and at this time it's unclear if there's a direct morbidity or mortality benefit of a balanced isotonic balanced salt solution over normal saline. The other option for fluid management is colloids, which contain large insoluble molecules which increase the intravascular narcotic pressure. First option is hydroxyl ethyl starch. It's been studied versus crystalloids, and it's been found that overall there's no clear benefit, but it does carry possible negative effects like renal injury and coagulopathy, and so it's rarely used. The other option is albumin. There was a large trial called the SAFE trial, which showed higher mortality in the albumin group in neurosurgery patients, although it was somewhat controversial. Basically, albumin use is questionable in neurosurgery and should be taken as a case-by-case basis. So what really is the optimal fluid therapy? Again, the primary goal of perioperative fluid management during neurosurgery is to maintain hemodynamic stability and an adequate cerebral blood flow. In the 1980s, looking back, in severe traumatic brain injury, the management usually involved fluid restriction, but this accompanied with using hyperosmolar therapy to treat cerebral edema caused dehydration, which could be severe and was of special concern in traumatic brain injury, which, because the dehydration eventually caused a direct reduction in cerebral perfusion pressure with subsequent hypotension. And so in recent decades, more studies have been shown that fluid overload actually seemingly has worse outcomes with increased acute lung injury, prolonged ventilation, and increased cerebral edema. So, taking a broad overview, you really want to avoid overhydration, but also excessive fluid restriction. So this is a 2021 study from the Lancet looking at 50 centers in Europe and Australia, examining the impact of fluid balance on outcomes in 2,125 critically ill patients with traumatic brain injury. 42% of the patients had cranial surgery, 31% had extracranial surgery, and the hyperosmolar therapy was used in 27%, and interesting colloids in 16% of the patients. And what they found was at 6 months, 46% of the patients had an unfavorable outcome, which was assessed by the Glasgow outcome scale. And a mean daily positive fluid balance was associated with higher ICU mortality and a similar unfavorable outcome on the Glasgow outcome scale. They also saw similar results across multiple sensitivity analyses, including adjustments for cerebral perfusion pressure and serum sodium. In an instrumental variable analysis, higher fluid balance was again associated with mortality and an unfavorable outcome. So seeing as how you don't want too much fluid or too little fluid, especially in neurosurgery patients to maintain euvolemia, goal-directed fluid therapy is an emerging technique to find this happy medium. And it uses predefined fluid targets based on directly measured hemodynamic parameters like cardiac output, stroke volume variation, pulse pressure variation, and other factors to achieve the optimal target. There's this study that looked at stroke volume variation, specifically in neurosurgical patients, and they found that after induction of anesthesia and before the start of the surgery, the surgical procedure, stroke volume variation more sensitively predicted an increase of more than 10% in the stroke volume by lactated ringers infusion compared to mean arterial pressure, heart rate, cardiac output, or CVP. And they basically found that stroke volume variation was a sensitive predictor of fluid responsiveness, and saw 9.5% as the optimal threshold based on previous studies. And then a 2017 BJA paper looked at stroke volume variation again and found that lower stroke volume variation had lower postoperative lactate levels, shorter ICU stay, and lower postoperative neurological events in neurosurgical patients. In addition, the pulse pressure variation has also been shown to be useful in PPV-guided goal-directed fluid therapy. And again, another study looked at pulse pressure variation and found that it had a comparable brain relaxation scale and a low serum lactate compared with conventional fluid therapy. So it seems that this might be able to achieve the happy medium of euvolemia that has been elusive thus far. And with that, I think I will end my presentation. And these are my references. Thank you very much.